Hello, I am Dr. Sandra Buzoglu, and I welcome you to my talk on breast augmentation on TouchMD. Before I get started, let me tell you a little bit about myself. As you may have already seen, I am board certified by the American Board of Plastic Surgery and have been in practice since 1990. Breast surgery, from reductions to augmentations to even reconstructions, have always been my specialty. In 1998, I established Kentucky's first accredited outpatient facility of its kind to provide privacy, but above all else, safety for my patients. Over the years, we have successfully performed over 3,000 cases with no infections. We have also come to learn all about how the internet can be used to help our patients become educated on the various procedures we offer before they ever come into our office. Recently, this has proved to be extremely useful during the COVID pandemic. Years ago, we joined TouchMD to provide an educational platform for our patients so that they can simply log into TouchMD in the privacy of their homes, like you're doing probably right now, as often as they like during the course of their treatment. This talk is primarily centered on breast augmentation, and we'll touch a little bit more on breast lifts as well, since many of our patients also require lift at the time of breast augmentation. So, I hope to instill in you, through this talk, that the key to success is to have realistic expectations. We find that better informed patients are able to communicate their needs and their expectations if they understand the surgical process. Hopefully, you are watching this video before your consultation. Please write down and bring with you any questions you may have. We are hoping to make you look as good as we can so you feel good and therefore instill more confidence and help you have a better positive outlook. Breast augmentations have always been a very popular procedure with newer, safer implants and methods to enlarge the breasts. They've become even more popular. So, what is the diagnosis? The diagnosis is known as mammary hyperplasia. It just means small breasts. This can occur when a woman simply just never developed the size breast tissue she wanted. It could be involutional, like after a pregnancy. It could be after a weight loss procedure, or it could be unilateral, where one side just never developed. Every patient's different, and no two patients have the same procedure. There's always some variation. Why consider this? Well, it's for yourself only. Someone else may want them bigger, but remember, the larger they are, the heavier they are, and the more difficult it is to carry them around or even fit in clothing. Also, there's only so much we can stretch the skin out to. Goals. What are our goals? Well, hopefully you all want to create more normal proportions and satisfy your psychological needs. To reestablish size and contour may be similar to when you were pregnant. Our goal is always to maintain normal softness and sensitivity, to make you look normal, and to maintain function. So if you ever wanted to breastfeed, you should be able to. Of course, there's no magic potions that we can do to help stimulate normal breast tissue to increase in size. And unfortunately, without a mastopexy, we cannot eliminate stretch marks or create younger skin. Sagging may need to be corrected in addition to placing an implant. And typically the rule is when the nipple is pointed downwards or it's located below the inframammary fold when you're standing, then you're probably going to need a lift. Sometimes also, if the skin is very thin and there's just no elasticity to it, a mesh type of material might need to be used to help support the implant, since the skin cannot support the implant by itself. It just depends, and we'll decide on that when we see you in person. Asymmetries may also persist, especially if they involve the underlying chest wall. After all, I'm not operating on the chest wall, and one side of the chest wall may be larger than the other. And of course, we don't solve personal problems, and goals may only be partially met. In other words, there's just so much we can do. What about the alternatives? Well, number one, it's an elective procedure. Just remember that. So there are no magic medications, of course. Surgery is still the best alternative. And either we use fat which is becoming more popular, or we use implants. Implants, however, today are still the best choice. Fat usually requires multiple procedures and therefore is more expensive. Can be many procedures, like greater than 6 procedures, to achieve the size you want. It's also more unpredictable. The amount of fat available can also be limited, especially in a very thin patient. However, fat is a good adjunct when needed to supplement the upper pole of the breast or to camouflage some rippling that might be present from an underlying implant. I also have found that fat is particularly useful for our breast reconstruction patients to help with their upper pole fullness and to soften and contour the breasts if they've had radiation. Fat is becoming more popular in all patients who want to augment their breasts, and I'm sure as we evolve with better techniques in fat harvest and transfer, we'll be using fat more and more for breast augmentation. The technology is just not there yet to get rid of implants. So, what about implants? Well, are all implants silicone? Yes, they are. Okay. All implants are silicone, but they're either filled with saline or salt water or they're filled with gel. Oftentimes I get asked, well, no, I don't want silicone implants. Well, right now we really don't have a choice. They're all they're all covered by silicone. And again, they're either filled with saline water or some form of silicone gel. So whenever I meet someone in the office who is interested in breast implant surgery, whether it's for breast augmentation or breast reconstruction, the number of implants that are available on the market can be very overwhelming and very confusing. We'll show you all the different types of implants when you come into your consultation, but for the purposes of this presentation, I'm going to give you a little introduction. First, you want to choose between a saline or a silicone-filled implant. Remember, they both have silicone gels, but the filling material in the saline is filled with water, whereas in the gel, they're filled with the gel implants, they're filled with some form of cohesive gel implant. One of the advantages of having a saline implant is that if it ruptures, the body's going to absorb that fluid right away. Okay, this obviously does not occur with the gel implant. But there are downsides with the saline implants, is that you can feel rippling. They don't feel as natural, and sometimes the rippling can be seen through the skin. Thankfully, however, with liposuctioning fat from another area of the body, the fat can be grafted to help address the rippling problem. Fat grafting can also improve contour as well as help with augmenting the volume of the breast. There's also some newer saline implants out on the market, which I'll show you in a few slides, that help address the rippling problem. This is called the ideal implant. I've placed a few of these, and so far they've been very nice. Another difference between saline and silicone is cost. Saline implants are much less expensive. Gel implants, and especially as they become more cohesive, are much more expensive. As far as textured versus smooth, well, we no longer have the textured implants, and I'll discuss why in a few slides. So today, they're either cohesive implants or they're saline filled implants. As I said, most of our implants are gel. The 3 leading companies that produce gel implants today are Mentor, Allergan, and Sientra. Mentor has 6 different shapes, Allergan has 12, which can be very confusing, and Sientra has 5. But the greater number of shapes with Allergan gives us more versatility in picking an implant that will fit our patients. The major advantage of the cohesive gel implants is also their durability. They are less likely to leak because since they hold their shape better, they typically don't cause fold lines to develop that would put strain on the implant like a saline implant would. Cohesive gel implants are made with a semi-solid interior, so if there's a rupture, the gel will not migrate very far. The more cohesive they are, the more likely they are to maintain their shape and provide upper pole fullness. The less cohesive they are, the more natural they feel. However, their incidence of capsular contracture is slightly higher. So the more cohesive, the more expensive. Most of our patients like to choose something that's of middle grade cohesive called the soft touch implant. It's nice because it is a cohesive implant. It does give you a little bit more upper pole fullness, but it doesn't have the natural firmness that a more cohesive implant does. Again, you will have plenty of opportunity to spend in the office to feel all the implants we have. Try on different sizes, feel the different shapes, and what I would recommend is that you choose an implant that feels more like your own breast tissue. So here are two examples of cohesive gel implants. The one on the left is more cohesive than the one on the right. As the implants are turned, you will see that both implants do assume a more teardrop shape when in the standing position. In addition, the implant on the left is more cohesive and shows more upper pole fullness than the implant on the right. Another decision you're going to need to make has to do with projection. You can tell there are 3 different gel implants with 3 different profiles here. This allows a choice between one that is more for shape rather than an increase in size, like the one on the right. So the one on the left is a low profile implant, has a wider base, but has less volume. These are usually used on breast reduction patients who want to maintain some upper pole fullness, but of course want to minimize the increase in the size of the breast that an implant might perform. Over to the right is a full profile implant, best for patients who want the maximum amount of volume that they can achieve for a given width of their breast. These are most often used in breast reconstruction patients who are trying to achieve the most volume they can. Most of our breast augmentation patients choose the middle implant, the moderate profile implant, which gives them adequate volume without overstretching the overlying skin. This is a Mentor cohesive implant, which shows that when it's cut, it does not leak. The gel stays in place and it's not absorbed by the body. Like I previously said, these implants are a little firmer, do not feel as natural as the less cohesive implants. However, they do provide upper pole fullness, and the most so of any of the implants. And again, they have less of a tendency to leak and less problems with capsular contracture. Well, what about this ideal implant? Well, number one, it's a saline implant. It's extremely new, and we don't have long-term data to report on its longevity. However, it is a very nice implant in that the manufacturers of this implant have been able to decrease the chances of rippling and make an implant that almost feels as natural as a gel implant. Here's a picture of what it looks like. This is the ideal implant. It has 2 ports, one in the front, one in the back. The back port allows the larger lumen to fill, whereas the front port allows the front lumen, which is much thinner. The downside of this implant, unfortunately, is that their sizes are so limited and their shapes are so limited that it's difficult to fit all patients. Otherwise, it's a great implant, and it actually feels very much like a gel implant. So if you're concerned about silicone gel implants and this is something that'll fit you, it is a nice alternative. So what about breast implants and breast cancer? Number one, there is no evidence that there's any increase in the incidence of breast cancer or decrease in the incidence of breast cancer related to breast implants. However, I can tell you that over the years I have found that it is much easier to feel a early on breast cancer in patients who have a smooth implant behind their breast tissue. And so this has led to breast cancer being diagnosed, if it is going to be diagnosed, at an earlier stage in women who have breast implants. After a breast augmentation, make sure you notify the radiologist that you have implants. You may require special mammograms. It is recommended by the FDA when they released the gel implants back in 2006 or 2007 that women with gel implants should get an MRI at 3 years post-op and every other year thereafter to rule out a leaking implant. MRIs are not 100% going to rule out a leak. Leaks usually occur after some significant trauma and will be noticed as a change in the shape of the implant or the change in the shape of your breasts or the softness, like all of a sudden you're going to feel that it's hard. Last, you may have heard in the media that breast implants cause ALCL, known as anaplastic large cell lymphoma. This has been shown to be related to textured implants, which have been removed off the market. And I'll discuss this process a little bit later in my talk. So, where is my procedure performed? Well, you have your choice of either the surgery center, that is our accredited outpatient facility attached to our clinic, the hospital, or an outpatient facility. As I said, our facility, known as the surgery center, is accredited by QuadASF. It's an accredited facility, the American Association for the Accreditation of Ambulatory Surgical Facilities, or QuadASF. It is managed by surgical techs and RNs that actually come over from the hospital. It is much more personal and private, and yet also a lot safer than a hospital. And the reason being is that it has a much lower risk for infection. The protocols that we follow in our surgery center have been set forth by QuadA that are extremely stringent and on par with anything that a hospital has. So fortunately, we offer the personal and private space that our patients do much better. Yeah. Again, it's up to you. Okay. We want you to feel comfortable wherever you want to go. We have found also that by performing the procedure under a local anesthesia with oral sedation, this allows for much more rapid healing time and less recovery from anesthesia. Preoperative considerations. So we're going to tell you that preoperatively, we'd like you to stop your aspirin or anything that contains ibuprofen for at least 1 week before and 1 week after surgery. We ask you also to stop or discontinue any estrogen. There's no magic time, but typically a month before. If you are on an estrogen patch and you find that you start developing hot flashes just 2 or 3 days after removing the patch, then just remove the patch 2 or 3 days before surgery. We also would like you to stop any types of herbal supplements or vitamins 1 week before surgery. Your postoperative medications will be Percocet, there'll be an antibiotic, and then there'll be something like ondansetron or Zofran in order to help problems with nausea or vomiting. These will be e-prescribed directly to your pharmacy, and they are only for postoperative use. Do not take any of it before surgery. If you're on any blood pressure medications, please bring them with you to surgery, but all of your other medications you should be able to leave at home. So what happens on the day of surgery? Well, when you come in, we're going to bring you into the preoperative room, check your vitals and check your weight. Then I'll come in and do all the markings, and we'll take more pictures. And then we'll go ahead and sedate you. And the sedation, again, is orally. We give you usually a Percocet or a Lortab. And then in addition to that, some Valium and an ondansetron, as well as the antibiotic. Once you're sedated, we'll also put an IV in. The IV is just a port. It will not have fluid going towards it or in through it. It's just a port for access in case we need it. And then we'll go ahead and take you to the bathroom to make sure you do that before you take you back to the operating room. In the operating room, we'll place all the monitors on, including intermittent compression hose stockings, EKG monitors, blood pressure monitors, and your oxygen saturation monitors. The skin will then be prepped and draped by our nurses, and then I'll go ahead and start the local anesthesia part. The local anesthesia is put in very slowly. It is targeted to minimize pain and to not put in too much fluid. The local is placed in areas that will allow you to be completely numb. You'll still feel me, but you'll be numb. Once the pocket is created, we'll then use a funnel, and I'll show you in a couple slides what that looks like, to insert the implant without actually touching the implant. And then we'll sit you up so you can look down and agree on the size, the shape, and the placement. Our patients generally love this part. And then we will close the incisions as long as everything looks great. And then we apply a dressing and an ACE wrap. And we will then make sure that you're fine, that you're awake and alert, that you can go to the bathroom before we send you home. The procedure overall takes generally about an hour if it's just a breast augmentation. So technically speaking, as I said, I mostly place the implants below muscle to make it easier to obtain a good mammogram. These are the 3 different incision ports on the right. We can either go in the inframammary fold, around the areola, which I used to use on saline implants, or in the armpit. Generally, we use the incision in the inframammary fold to allow good placement through a small incision that is typically about 4 centimeters long. It usually heals very nicely, and if well cared for with vitamin E and silicone gel, the scar should virtually disappear. This is an example of an implant coming out of a Keller funnel. The implant is first prepared in its packaging container with antibiotic solution prior to transfer, and with ever touching the implant is then transferred through the funnel and subsequently into the implant breast pocket without actually touching the overlying skin. It's actually ingenious and makes breast augmentation much easier. So breast augmentation, as I said, is an outpatient procedure where you come in, you have your procedure, and you go on home. However, the procedure is performed in our surgery center at the hospital. Someone needs to be present when you arrive for your procedure to affirm, number one, they'll be caring for you postoperatively, and that person also needs to stay with you for the first 24 hours post-op, even though your procedure is being performed under local anesthesia. You will also have access to my mobile number so you can call me directly anytime. We typically see patients 2 days post-op. Just before your appointment, you will remove the entire dressing 2 days later and take a shower with antibacterial soap. All of this is provided for you in your postoperative kit. Make sure someone is with you the first time. Do not touch the incisions with your hands or with a washcloth or a loofah pad. Make sure you just use some clean gauze that's provided for you, as well as the antibiotic soap that's provided. If you have any questions, please don't hesitate, just contact me directly. After your postoperative visit, we typically see patients at their 3-month visit. However, I'm happy to see you anytime in between. I can be reached via phone or text or whatever you like. If you do not answer immediately, just leave me a message and I will get back to you. So trade-offs. What are some of the trade-offs? Well, yeah, there's going to be some discoloration, some swelling, some discoloration. There'll be some discomfort. We do give you Percocet. I don't usually give out more than about 5 to 10 tablets, mainly because you don't really need it. And when you don't need it, Percocet just causes constipation. That can be worse. I would suggest that you try extra strength Tylenol as soon as you can. It actually works very well. There may be some numbness that's normal. They may feel tight initially. Later on, it relaxes. There may be some lumps. That's not unusual. What's important, though, is to restrict your activity, especially for 3 to 4 weeks post-op. You don't want to be pulling or pushing or anything like that because you could very easily tear the fragile tissues inside and cause bleeding. Some other trade-offs, well, there's always scars, but the scars do very well as long as you take good care of them using vitamin E and silicone gel. The tendency towards firmness have been reported from anywhere from 1 to 10%, even upwards as much as 45%. There's always a lifelong need for follow-up. Implants don't last forever. And typically we say about every 8 to 10 years is when you need to have an implant change. We're not saying to schedule it that way. We're just saying that that's typically what we find is that all of a sudden the implants might feel a little firmer. Your breast might start sagging after 8 or 10 years. We might need to do a lift. implants might have changed. All kinds of things can happen. So typically, just plan on them being around for about 8 to 10 years. Although we've had some patients have them in for even longer than that. So typically, there's also the regular risk and complications related to any kind of surgery. Bleeding, infection, numbness, asymmetry, and swelling can happen, especially because we're putting the implants below the muscle. The muscle sometimes can go into spasm and create some swelling up on top. All of this gets better. It takes a good 3 weeks or so, but eventually gets better. I've talked many times about wrinkling with the saline implants, thinning of overlying breast tissue, capsular contracture. But again, it's not very common. I have not seen it very often. An ALCL or the anaplastic large cell lymphoma, that's very rare. And again, only with the textured implant. So what is ALCL? It's a very rare cancer of the immune system. It is specifically associated with textured implants. So if you have a smooth implant, you don't need to worry. Studies have shown that there's an increased incidence of ALCL with Allergan's implants as opposed to Mentor, although they've been seen in the Mentor implants as well. The theory behind the ALCL is that when a textured implant is placed in a woman's breast, either in an augmentation or reconstruction, sometimes bacteria can get into the crevices of the implant, causing the immune system to react to those bacteria to clear them out. However, because these bacteria are inaccessible, over time, an average of 8 years is what it takes for ALCL to develop, the immune system is reacting chronically, therefore being overstimulated and developing into cancer. So what is the risk? As of July 2019, 573 women worldwide have been diagnosed with it, and there have been 33 deaths. It's very rare. 1 out of 17,000 risk of dying. The signs and symptoms, if you happen to develop that, you will find swelling. That's the most common. Swelling on one side, an average of 8 years after implantation. So if you notice swelling, especially just on one side or any time, just number one, see your plastic surgeon. Okay. If it is possible, if it is found that by ultrasound guidance they aspirate the fluid and the fluid is found to have ALCL, it is recommended to remove both implants with the surrounding breast tissue. And that effectively eliminates the ALCL. You can actually have new implants replaced as well. The FDA has stated if you'll feel fine and you have no swelling, then no further treatment is needed. Although I would say close follow-up should be done. And especially if you're anxious about these implants, just go ahead and get them replaced. The implant manufacturers have been extremely helpful in replacing the implants. The American Society of Plastic Surgeons does have a couple of breast implant registries. Profile is the registry that focuses only on ALCL. But the second one, the National Breast Implant Registry, includes all women who have had breast implants to track their data. All of our patients are automatically registered in this registry after the implants are placed. So if for some reason we lose your medical record, we can go directly to the manufacturer. I don't say that's going to happen. All of our records are electronic, and I have saved all of my records for all the years I've been in practice. However, this is just an extra location for the implants. This is an example of a patient of breast augmentation with Allergan saline implants. And I just show you this as an example. She went from an A cup to a C cup. Saline implants can look very natural. Other risks and complications can result in more surgery, more hospitalization, more time off from work, more expense to you. As far as implant warranties, it's very nice that the implant manufacturers these days do have warranties on breast implants. With the gel implant, it's included in the price of the implant. And at the time of this talk, their warranty was up to $3,500 as long as we showed a rupture and it was within 10 years of the time that your implant was placed. There's always been a lifetime replacement of implants by the manufacturers, but in terms of any monetary recoupment from the manufacturers for the surgical procedure, this has come to light just since 2008. Capsular contracture, they also have a warranty for that. And most recently, the warranty is only if it occurs within the first 2 years. They, again, will replace the implant and provide $2,000. Warranties, however, do change frequently. So even though I'm listing this in my talk, it can very well be changed even next month because the implant manufacturers are always changing their warranties. This is a patient who had a deflation on the right side from a saline implant. She was about 5 years out from surgery. When this occurs, you're going to notice it immediately. It's just a sudden deflation. And so here she is a week out after her surgery. If you do sustain a deflation from a saline implant, the sooner you have it corrected, the easier it is to replace the implant. So don't wait. Rest assured that it is much less painful to have an implant replaced than it is to have inserted the first time. You barely even need sedation, actually. We could do this under straight local. Patients often ask if breast augmentation is covered by insurance. Well, no, only if you have breast cancer can they be covered by health insurance. So we do have some finance plans available, which our patient care coordinator will be happy to discuss with you. Revisions are also not covered by insurance. However, if performed within 1 year from surgery, I do not charge a surgeon's fee, but there will always be a facility fee, which is usually just to cover the overhead and supplies. If you follow your postoperative instructions and maintain your postoperative visits as scheduled, you will qualify to have a revision as long as it's planned or performed within 1 year from surgery. There's still no guarantees. Just remember, we hope for the best results, but there's no warranty expressed or implied by anyone as to the results that can be obtained. Okay, what about costs? Well, I'm not going to get into all the specifics because there are so many categories when it comes to breast implants. However, generally, the fee range between $6,000 to $12,000. It just depends. Depends on the type of implant you're going to choose, on how much cohesiveness there is, whether you need a lift or you don't need a lift, if there are any asymmetries, if one nipple is higher than the other, or one breast is larger than the other, do we have to do a reduction on one side? There's all kinds of things. Do we need to use mesh? Mesh is expensive, and that's going to add to the cost of the augmentation. Or what about fat? Okay, that will also add. So, but the best part, though, in our surgery center is that there are no anesthesia fees. So if you're going to look at cost between hospital and our surgery center, you usually end up winning in that there's no anesthesia fees in our surgery center. This is a patient who came to me for a breast augmentation, and her postoperative result about a year down the road. She could have used a lift, but she's actually very happy with it, with her procedure. If you notice, her nipples are not quite perfect. But again, she's very happy with her size and her shape. This is her side view pre-op and her side view post-op. One of our other patients who did not need a lift, her pre-op and post-operative picture. Another patient who really wanted to be quite large, and she does have a little bit of asymmetry. Her right nipple is a little bit lower than the left, not a huge amount, and probably she just didn't want to deal with the scar around the entire areola on the right side to even that out. But what she wanted was very large implants and wanted cleavage, and we were able to help that for her. Another patient who I felt needed a lift, and as you can see, her nipple is below the inframammary fold. It's not pointed downwards. But again, she was extremely happy with her procedure postoperatively. She liked the size, she liked the shape, her breasts were soft. Were they lifted? No, but she was extremely happy still with her implants. This is the last example of a breast augmentation only that I am going to show you. This patient weighed 115 pounds and had 350 cc gel implants placed behind the muscle. You can see preoperatively in her pre-op pictures that her nipples are well above the inframammary fold, so a lift was not necessary. And the scar is well hidden down in the inframammary fold. You can't see it on this picture. We have many more pictures to show you, but just take a look at the TouchMD gallery if you'd like to look at more. Just remember, everyone is different and results vary between patients. I hope you have found this talk educational and maybe even a little entertaining. Write down your questions and bring them with you to your consultation. Thank you so much for watching, and I hope to see you soon. Here's to you looking good to feeling good.